Hi, everybody. Thanks for joining us this evening. I'm Dan O'Connor. And just a couple of things before I kind of get into the talk. Feel free to enter questions into the Q&A chat box, or excuse me, in the Q&A section. And some of those will be answered by the team just directly, and then others I'll just answer at the end. And then this webinar is going to be recorded, and there'll be a link to the recording that's going to go out via email probably tomorrow evening. With that, I'll just kind of get started. What I was planning to talk about today was just sort of advances in knee replacement. And first, I'll kind of just give a little background on myself. Let's see if I can't get the screen to advance. There we go. So my background, I'm from California originally. Studied at UC Berkeley. For undergrad, ended up at UC Davis for medical school, and then was lucky enough to stay for orthopedic residency. So I did 5 years of general orthopedics training with that. And then I elected to do subspecialty training in joint replacement specifically. And so was at the University of Chicago doing that for a year. And a trip with one of my my instructors actually brought us out to Colorado. And I fell in love and was very excited to get the job here at Valley View. Yeah, I've just absolutely love the Valley. My family loves it. It's fun to be able to do all the fun things like fly fishing and hiking and skiing and all that stuff. With that, I'm going to just jump in and just a little overview of what we're going to do today. We're going to talk about the knee itself. We're going to talk about arthritis. And then we're going to talk about total knees and partial knee replacements, and then some new alignment techniques or concepts, as well as some new changes to implants, things like robotics. And then I'll give you just a little bit of an overview about total knees as well at the end. And so, like I mentioned, if you got any questions, just throw them in the Q&A, and we'll try and get to them at the end. With that, so just some sort of basic knee anatomy. When I talk about a knee, I talk about the medial side of the knee. That's sort of for the midline, and the lateral side of the knee is out to your side. The front of the knee we call anterior, and the back of the knee we call posterior. Then the knee itself is very complex. It's a complex joint. The ends of the bone are covered with what's called articular cartilage. There's a meniscus fibrocartilage shock absorber sort of between those two. And then the knee is stabilized by many ligaments and muscles that cross that knee joint. There are three major parts of the knee joint that articulate. There's sort of the medial side of the joint between the tibia and the femur, and the lateral side of the tibiofemoral joint. So when someone says my knee, they're typically talking about that joint, although the knee itself does include another joint, the patellofemoral joint. That's the joint between sort of our kneecap and our femur that's mostly engaged when our knee is bent. Now, I mentioned it's kind of complex anatomy about the knee. This is just a general overview that's not actually fully complete about all the structures that are around the knee. It's primarily driven, your knee function is driven mostly by your quad muscles and your hamstrings. But there's a lot of nuance to that and how that works. Knee arthritis is sort of a degenerative wearing out and dysfunction of the knee joint. It happens for a variety of reasons. A large percentage of that is actually genetic. It's probably 20 to 30%. Of why we get arthritis is just genetics. You may just happen to have it running in the family. Another thing is age. Over time, we just sort of get more wear and tear. And then the heavier we are, the more force we put on our knee, and the faster we wear it out. And then things like injuries. So tearing your ACL or being in a bad car accident, all those things, when you have that injury, the cartilage on your knee takes an impact, and it can be many years later before you actually experience the effects of that impact or the damage on the cartilage. Some things like occupation. People who often are in a kneeling position or a bent knee position, or people who have to lift heavy loads consistently. Think of like construction workers, masons. They put more force on the knee and they wear it out. And then some people just have medical conditions that can cause arthritis. So you can think of autoimmune disorders or rheumatoid arthritis, things like that. They can attack the knee joint. and damage that cartilage. So when I say knee arthritis, I'm primarily talking about damage to that articular cartilage. And when that happens, you often get narrowing of your joint space. You can see on this image, there's a healthy knee on one side and an arthritic knee on the other. You lose that joint space and you start to get irregularities and bone spurs that grow in the knee. That's typically what drives the pain. Is actually, it's not the cartilage itself that hurts, it's the bone beneath the cartilage that is causing the pain as it experiences those abnormal forces because it doesn't have the normal surface. And so typically when we talk about knee arthritis, people usually have knee pain. They often have pain at night. They can have swelling or stiffness in the knee. Sometimes it feels difficult to do stairs. Patients often know it's worse going downhill or downstairs. And sometimes you get the snap, crackle, pop, the crunching in your knee with motion. That's when you have that irregular arthritic surface sliding on the other surface instead of nice and smooth. And there can be a feeling of weakness or buckling of the knee, feeling like it's going to give out. And some people even have pain when there's a change in weather. They can talk about, oh, my knee's acting up, we must be getting a storm. That's about 30% of people can actually feel that. And usually activity will worsen the pain when you have knee arthritis. Arthritis is very common. There's millions of Americans who live with this on a daily basis. About 40% of people over the age of 60 have knee arthritis. We diagnose it based on physical exam, your symptoms, as well as using x-rays. And like we talked about, seeing the bones get closer together because there's no cartilage keeping them apart is one of the ways that we see knee arthritis. The interesting thing is that the x-ray doesn't always correlate with how the patient's doing. So half of people who have an x-ray that looks like it has arthritis don't have symptoms. And so part of the arthritic sort of condition is that joint space narrowing, but part of it, we aren't 100% sure why some people just don't have any pain with significant knee arthritis. And we sort of grade arthritis from no arthritis to bad arthritis, 1 through 4. And that's just based on how much change we see on those x-rays. Now, our knees have an alignment. And what I mean by that is when we stand on our leg, the force goes through our hip, through our femur, across our knee, down to the ground. And all of us have a slightly different alignment. So there's a normal or what's called neutral alignment, where the hip is right above the knee, which is right above the ankle. And then there's what's called valgus alignment, where people will refer to this as being knock-kneed, where the knee is pointing in and the foot's pointing out. Or the opposite, bow-legged, also called varus alignment, where your knee bends out and your foot bends in. This is an x-ray of what that looks like. And we're all somewhere on this spectrum of varus or valgus. Some of us are sort of normal or neutral. There was a study where they looked at all the different, shapes of legs and how they're aligned. It turns out that there's a pretty small percentage of us that have just a nice straight leg alignment. It's probably about somewhere between 5 and 10% of us, whereas the rest of us are somewhere on that spectrum. We're a little knock-kneed or a little bow-legged. Why does that matter? We'll get to in a little bit. Now, when we have knee arthritis and we've exhausted all the options like physical therapy, injections, anti-inflammatory medications, weight loss, all those things, and it's still the anchor of our life, where our life is just getting small because of our knee pain, we're not able to do the things we need to do, then we think about surgical intervention. This is what I do for a living. I replace knees and hips, but I like to say, keep your own parts as long as you can. And so surgery is sort of that last resort. And surgery can either be what's called a partial knee replacement or a total knee replacement. And I'll use the words replacement and arthroplasty the same. They just mean sort of resurfacing that knee. And when you have arthritis in one area of the knee, just one part of those 3 compartments we talked about, sometimes you can get what's called a partial knee replacement or a unicompartmental knee replacement. Some people will call this a partial resurfacing of the knee. And this can work well. It's a little bit less, not a little bit, it's quite a bit less surgery than a total knee because you're only replacing part of that knee. The recovery is a little bit easier. But there's always a chance that you wear out the other compartment or the other side. And so that's one thing to consider. A total knee replacement, when you have arthritis throughout the knee, what you do is you actually resurface that articular surface. So you've got a knee, it's got arthritis on it, and you remove that arthritic joint surface and you replace it with metal. And you literally just cap the end of the bone. Total knee replacement is much more common than partial knee replacements. And it's a very common procedure. We do a couple 100,000 of these a year in the United States. The partial knee replacement we talked about is for when there's only one area that's arthritic. And you can do it in the inside of the knee, so the medial side or the lateral side, or it can be that patellofemoral compartment. Sometimes people will even get two partials and leave one side alone. The main drawback, if you want to consider a drawback, is that there's a chance, because we left the rest of the knee intact, that the rest of the knee could get arthritis, and it could go on to have arthritis in the area that you did not resurface. And sometimes you have to then convert that to a total knee. The 10-year survival, so meaning you put the implant in, and 10 years later, how many people still have that implant, is about 90 to 95%. The 10-year survival on a total knee is a little bit higher. It's probably 98, 99%. Essentially, this is the most common thing is to do a total knee. When we look at sort of how satisfied are people with their total knee, that's changed over time. It used to be pretty solid. 80% of people were satisfied with their knee replacement and 20% were not. That's about a 1 in 5 chance of not being happy with that knee replacement. With modern techniques and some advances, we've probably pushed that number higher. Some studies suggest 90% are happy. A few studies suggest 95% are happy. So we have improved over time, but it's still not 100%. There's still a 1 in 10 chance or so that people may not be happy with that knee. And that's why we say, wait as long as you can before you do it. And the knee replacement itself, like I said, you cap the end of the bone. The femur side is actually a metal implant. This is a real one that just goes right over the top of the bone. It's kind of like capping a tooth. And then on the tibial side, we remove the surface and we put a metal tray into the tibia. And then we put a piece of plastic that goes between those components. Okay, and that's what a total knee looks like. In traditional knee replacements, we're going to talk a little bit about how total knees are done. Traditionally, well, before I get there, remember I talked about not so many of us are in this perfectly straight alignment. Most of us are somewhere on the spectrum. 85% of us probably are not just perfectly straight in our alignment. Now, this matters because the traditional way to do a knee replacement is what was called mechanical alignment. This is what was initially done when we started doing knee replacements. So the first knee replacement that's been reported was done in 1968. And since that time, we've increased how many we do, and we've changed greatly the technology. The initial implants were pretty primitive. Sometimes they were just a metal hinge with a big spike on the end. And we've made significant improvements by that. But one of the things that resulted is that when arthroplasty was growing as a field, they made this concept of we want the implant to last. And so what we're going to do is we're going to cut everybody's knee the same, regardless of what alignment they had. Everybody's getting the same cookie cutter. We're going to put that tibia 90 degrees. We're going to make a cut. We're going to put those implants in. And then what we're going to do is to make the knee balance and flexion and extension, anything that's tight, we're going to cut it. And so that uses the concept of you need to make this thing straight so that there's equal forces. And if once you put it in straight, the ligaments don't balance, well, you have to cut them to make it balance. Now, this was a concept that at the time made a lot of sense because the technology that they had was was very primitive. It's so primitive as to like take a string and put it where the hip is and put a string where the ankle is and try and line up the knee. You just kind of eyeballing things. And so that's where this concept of put the knee in and then balance it came from. And the whole goal was to try and make these implants last a long time. Now, the thing is that implant technology has improved immensely since 1968. Just like think of your car, like a car from 1968 from 2024 is very different in how it functions and in the technology in it. Same with implants. Now, they're not quite as complex as a car, but there's been great advances in technology. However, the idea of how to put a knee replacement in has not really changed much. And this is at the very bottom, I've got all these steps of what's called a medial release. This is one of essentially 4 different sets of releases that traditionally were trained on how to do. You just put the implant in, just you say it's everybody's 90 degrees, and then you cut all the ligaments to make it balance. And there's a series of like, okay, if you're tight on this side, this is what you cut. And if you're tight on that side, this is what you cut. And so in my residency training, this is how almost all orthopedic surgeons are trained to do a knee replacement. This is traditional way, mechanical alignment. Now, some of you are thinking, why are you cutting all the ligaments? Well, that's a very good question. That concept was challenged by some surgeons who were like, well, the knee isn't made like that. Why are we making everybody the same? No wonder we have people who are unhappy. We're cutting their ligaments. We're giving them a ligament injury, and then we expect them to be happy with the knee replacement. However, there was a lot of sort of institutional backing in the traditional way of doing it. Many people made their careers on how to do that little cut on that ligament just quite right. But there were some individuals who thought that this doesn't make sense. Dr. Howell, he's actually a sports surgeon from California who was studying where to put an ACL reconstruction tunnel to make the knee have the best kinematics, or the best motion and function. And he realized that total knees don't respect any of those principles of trying to get a normal motion. And so he decided, it doesn't make sense. We should do knees differently. We should do knee replacements differently. And so his concept was the knee has sort of 3 axes of rotation. And that's determined by where the bone is and how it's grown your whole life, as well as where the ligaments are. And when I do a total knee, why should I change that? Why should I change the position of where the knee joint is? And why should I cut ligaments to make it balance my artificially chosen position? And so his concept was we need an individualized position of the implant. And so the goal of what's called kinematic alignment is to put the knee replacement right where the old knee was before it got arthritic, to sort of reconstitute the pre-arthritic state and preserve the soft tissue envelope, meaning all the ligaments and muscles and tendons that go around the knee, we don't need to change them. You've grown your whole life with them. Why would I change it? I want it to feel normal. I want it to feel like your knee. I should respect those things. This technique was initially considered heresy by the establishment, and Dr. Howell wasn't well received for a while, but he's kind of a bulldog and refused to be quiet about it and kept publishing his data, and his data was just that his knees did better. And some of the younger generation of us surgeons said, yeah, why are we doing this the same way we did in 1968? That doesn't make a lot of sense. And more people started doing this alignment technique and publishing on it. And this past year, the Academy finally had to say, okay, the data says that kinematic alignment's as good or better than mechanical alignment, and it's an acceptable alignment technique. I got the privilege of studying with Dr. Howell and doing a lot of knee replacements with him and learning about this technique. And for me, this is a technique that really provides a more normal feeling knee with better function. This is sort of a diagram of what the cuts are for a mechanical knee on the right, mechanically aligned knee, and a kinematically aligned knee on the B, or I guess it's my right. I don't know if it's your right. And what you see is that on the mechanically aligned side, you just cut a box that's straight to the floor, but you're changing the position of where the implant goes. You're changing where the knee is. And kinematic alignment, you cut symmetrically so that you put the implant exactly where the knee used to be. And you don't cut the soft tissues. You restore the native joint line, and you don't change people's alignment. If they've grown their whole life with a little bit of bow-leggedness, and that's what they're used to, put them there. It's okay if their leg's still bow-legged. If they're a little knock-kneed and they've grown their whole life that way, and that's what their knees are used to, put them back there. Some of us develop more deformity over time as the arthritis wears out one side or the other. But the goal of kinematic alignment is to put it back to where it was before it wore out. For me, I think I had an excellent opportunity to study with Dr. Howell and do some knees with him. And I was blown away by how much better his patients did than the patients I was trained in residency, the traditional way of doing this. And every study to date comparing the two shows that kinematic alignment's as good or better than mechanical alignment. It's got better function, and it has a more normal feeling knee. To me, this makes sense because I'm not changing how the knee functions. I'm just getting rid of the arthritis. And I've been trained in both techniques, mechanically aligned and kinematically aligned. And I kind of had the option of what do I choose? What am I going to do for my patients? And to me, I think kinematic is the hands down winner, and that's what I do. It's not a very common technique yet. It's gaining popularity, and I think over time it's going to become the dominant way that we put in knees. But currently it's not. And kinematic alignment has a 98.5 or so 10-year survival rate. And so it doesn't seem to have complications where it wears out or it loosens, which is what people feared initially when they developed the initial technique. But people just do better with them. And then we talk about another advancement in knee technology is robotic assisted knee replacement. Just as cars have gotten smarter, phones have gotten smarter, we now have some robots that are smarter, and they let us put the knee replacements in very precisely where we want them. And it's just a very fancy, very precise saw. And the surgeon has to pick, where is he going to put that knee replacement? How's he going to put it in? You can still use the robot to put this in the traditional way, in the traditional place. Or you can modify that a little bit and you say, okay, well, I'm going to tweak it a little bit. The robot gives me some information, lets me balance the knee, do a little bit less soft tissue damage. Or you can do it and say, I want to do a kinematic alignment knee and use the robot to do that. And whichever technique you choose, the robot makes it very precise. It lets you customize that implant position a little bit. You can do it with a little bit smaller incision. It has some features that will protect the nerves and blood vessels in the knee, making it a little bit safer. It seems to have better survival in younger patients. And there's some studies that suggest that it has less inflammation using the robot than using the traditional instrumentation. And there's robotics and navigation. Navigation just tells you, okay, where to make your cut, but the surgeon still just uses a saw and does the whole surgery himself, whereas the robot has some control in that it won't let you cut things you don't want to cut, which is one of the reasons it makes it safer. This is something that I do utilize in my practice because I like the decreased inflammation. It's a little less invasive, and I think it's very precise in helping me put the implants where I want to. Another thing that's changed is that traditionally knee replacements were put in with cement, and you essentially put cement on the bone, you put cement on the implant, and you stick them together, and you hold them there until the cement dries, and it holds the implants on there. How we cement has changed over time. It used to be they just kind of stuck it on there and stuck the knee on, but they had problems with it loosening. And we've developed some better techniques in how we cement. Another thing that has changed is that sometimes we do what's called a press fit implant. This is an implant that does not use cement. These are typically like 3D printed out of titanium. They have a porous surface on the underside, which actually the bone will actually grow into the little holes and lock the implant to the bone. And so you can get very good fixation without cement. And some people are like, oh, this is it. This is going to solve all the problems. It's great. And I think it is good. And we know that in men, men who get a press fit implant have actually better survival of the implant. It's less likely to get loose or have a problem. However, in women, we didn't see that effect. We actually found that cement seems to have better survival in women, and particularly in elder women over the age of 70. There's a big benefit to cement. And part of that is that the press fit implant relies on very strong bone, and women have higher rates of osteoporosis than men do. And that's sort of a softer bone. And so when you have soft bone, you can't just press the implant in as well or as reliably. And cement still works very well for that. Some surgeons only do cement. Everybody gets cement. Some surgeons are the opposite. Everybody gets press fit. Some of us are a hybrid. I sort of split mine based on the data that I've seen, which is for my men who need a total knee, if they have good bone, they'll get a press fit implant. Or if I get in there and the bone is soft, I cement the implant. And for women, I typically cement all of those because it seems to offer a survival advantage. This is just a little bit of a demonstration of how different the technology is. It used to be that knee implants were forged in a foundry, and now they're 3D printed with titanium and lasers. And so the implant quality has gone up significantly. The goal ultimately of a joint replacement is to get you back to doing what you love to do. And with a knee replacement, we know that the inflammation associated with arthritis is also not good for us. And so there's actually an improvement in mortality, meaning your survival, with a knee replacement. And the idea is that you get rid of this source of inflammation. There's less inflammation in your body. You have less heart problems, less strokes. And knee replacements improve pain and physical function. When they do well, they can get you back to doing what you want to do. Now, it's still metal and plastic, and that doesn't heal. And so all total joints will eventually wear out. The old plastic we used to use probably lasted 12 to 15 years before it would wear out. And it would fail and need to be redone. So for that reason, it used to be that only patients over the age of, say, 75 got joint replacements. And then we made a little bit better version of plastic. And so then we crept the number down to about 65. In 1999, we started making a new plastic that seems to, it just really hasn't started to fail yet. And so we think that it's probably going to do 25 years. Some studies suggest maybe 35 years, which is another benefit, another sort of advancement in the technology. And so now knee replacements aren't just reserved for our 75 plus crowd. Most surgeons are probably around that. If you're 50 years old and you've got knee arthritis, many surgeons will consider doing that surgery because they seem to be so much more durable than previously. So in summary, total knee replacements, both the technology of the implant, how we stick it to the bone, how we make the cuts using a robot or not, using navigation, as well as how we choose to align the knee has changed significantly since 1968, which I think is a very good thing. Knee replacements are much more successful than they used to be. They're not 100%, but we're trying to get there. And partial knee replacements can be a great option for someone who has just arthritis in one area of the knee. That's great because it allows an easier recovery, a little bit better function, a more normal feeling knee. And kinematic alignment, this new alignment technique that says respects the soft tissue, respect how the knee was built, and everybody has a unique position of their knee, and everybody should get a unique position of their implant. It allows for much less soft tissue damage, better function, and a better recovery. And you kind of couple all these things together in new implants. You can use the robot to be very precise, to put it in kinematic alignment. It can be very, very successful. And that's pretty much what I wanted to share with you guys. I'd love to open it to questions. Yeah, let's see. I think we have some questions already.
Yes. Thank you so much. That was awesome. I learned a lot. Actually.
Okay, good.
So we have a few questions that people sent in prior to the talk that we'll go through, and then I'm sure we'll have some rolling in. So first question, we have a patient who was wondering about bilateral knee replacements and what the recommended time would be between surgeries, and then what sort of recovery time would be expected before they'd be able to be active in sports like skiing and biking.
Certainly. So often people who have arthritis in one knee will have it in the other. Usually there's one that's worse than the other, but sometimes they're equally as bad. And so there was this idea of, can you replace both joints at the same time? Save the patient hospitalization, just do one recovery. And that can be done. It does make the surgery itself much longer. So you're under anesthesia for essentially twice the time. And there's a little bit higher risk of cardiovascular complications. So anybody who has heart problems or lung problems, it's probably not advised to do both at the same time. Young, active, healthy patients, I think it's safe to do so. I will say this, the recovery with 2 knee replacements is very challenging. You don't really have a good knee to stand on until they recover. And so I do not typically do bilaterals myself. I will typically stage them. I usually stage them 6 weeks apart. The reason I do that is that the recovery from a knee replacement, most of the recovery happens early. So the first 6 weeks, you're going to have the biggest improvement. The first 6 weeks are hard. The knee replacements hurt. And then at 6 weeks, you sort of turn the corner and really start to get better. And at 3 months, you're about 70% recovered. And so 3 months is usually what I tell my patients for when are you going to get back to athletic activity or construction work or things like that. It's usually about 3 months, but I usually space them about 6 weeks apart.
Okay. We just had one more question come in kind of relating to activity, wondering what the maximum flexion is allowed after a knee replacement.
The maximum flexion is whatever you can get. There are certain countries actually where really deep flexion is really important. So most of the Asian countries where they squat for meals and the bathroom and things like that, to them, knee flexion is really important. So there's been a lot of ideas about how to make the knee flex as much as you can. About the most you can get a knee, even a normal knee to flex, is usually about 140 degrees. Arthritic knees are stiffer than that. And so, but I would say average for a total knee is probably somewhere around 120 degrees. If you get past about 110 degrees, you can do pretty much all your normal activities, stairs, ride a bike, hike, that sort of thing. And so we at least want 110, but sort of the maximum you can expect, the maximum is probably 140. But most people are in that 120, 130 range.
Okay, so our next question is kind of a specific to a patient related to bilateral knee replacements again. So we have a patient who had both knees replaced about 2 months apart. And after about 7 months after the first knee surgery, that first knee is continuing to be more painful and weaker than the other surgery that was done later. They're wondering if this is normal.
So knee recovery can vary. It depends on sort of how bad your knees were going in. It depends on how the surgery was done, what alignment technique was chosen. And so that's one of the big factors that goes into recovery after knee replacement. Knee replacement recovery is not very fast. Like I said, it's about 3 months till you're about 70% recovered. People continue to improve for about a year to a year and a half, primarily as a function of getting your muscles strong again, primarily your quad function. Some people do that very quickly, and some people take a very long time to do it. And so it's not unusual for a knee at, say, 6 or 7 months to still not be perfect. If there's lots of problems, if you're still getting lots of swelling, lots of pain, you have to be concerned about something like an infection or a problem with the component. And so you should be continuing to improve. And if you're not, it might be something to take a look at. I do revision knee replacements where if there's problems with them, trying to sort those problems out and see if we can fix them. But there's still, if it's sort of done in traditional alignment technique with some of the more traditional approaches, there's probably still a 1 in 5 chance that the knee is not as happy as you want it to be.
Another question that came in was about a tibial plateau fracture. After having a fracture, if they were to need a knee replacement, how quickly could that be done?
Yeah. So after a fracture of the knee, it depends a lot on how big that fracture was, how severe it was, and how it heals. If somebody has a bad fracture in that knee, about 20 to 30% of them are going to go on to get a total knee sometime in the future. But the majority don't need to. And then when you ask how soon after a fracture can you have a total knee done? If a fracture is bad and the bone is bad, sometimes you'll do a total knee right at the moment of the fracture, immediately. That's pretty rare. That's usually reserved for very frail people who wouldn't tolerate being non-weight bearing while they're waiting for that fracture to heal. But when you're putting a knee replacement into an area that has a fracture, you often can't use just the very slim primary implant. Sometimes you need to use bigger or revision components to get enough stability. So it varies quite a bit as to what you have to do when you can do that safely.
One more question, wondering about if it's common or how common it is to have numbness or nerve damage after a knee replacement.
So the nerves on the knee go from medial to lateral in the skin. So when you get an incision, you cut those nerves, and everybody gets numb on the lateral side. Anybody with an incision straight down the knee is going to have numbness on one side. Now, over time, that numbness area tends to get smaller, but most people will still have an area about the size of a quarter or nickel that's still numb. This causes problems because it can bother people when they kneel, because one side of your knee has sensation and one side does not, and it feels very strange. People don't like to do it. But having numbness on that skin it's not a risk, it's a guarantee. You will have numbness on the lateral side of the incision.
I think that's all of them.
Perfect. Thank you all for your attention. Our next webinar will be on May 1st with Dr. Inscore, talking about osteoporosis and bone health, which is super important. And again, the webinar is going to be linked via email. That'll come out tomorrow evening. Thank you guys for your time.